Today, we are going to educate cancer registrars about tumor size summary. My name is Kirsten McDowell, and I'll be the presenter for this topic. I would like to thank Babette Langeneckert for creating the slides for this presentation. So first, I would like to acknowledge the source of our funding, which is the Missouri Cancer Registry and Research Center, which is supported in part by a cooperative agreement between the Centers for Disease Control and Prevention and the Missouri Department of Health and Senior Services, and a surveillance contract between DHSS and the University of Missouri. So tumor size records the most accurate measurement of a solid primary tumor, usually measured on the surgical resection specimen. Tumor size is one indication of the extent of disease used by both clinicians and researchers. Tumor size that is independent of stage is also useful for quality assurance efforts. Tumor size clinical and tumor size pathological are not required in the state of Missouri. So today we're going to be focusing only on the coding instructions and coding rules of tumor size summary in this presentation. So for coding instructions, all measurements should be in millimeters, and we're to record size in this specified order as noted here on this slide. Size measured on the surgical resection specimen when surgery is administered as the first definitive treatment. And A, if there's a discrepancy among tumor size measurements in the different sections of the pathology report, code the size from the synoptic report, also known as the CAP protocol or the path report checklist. If only a text report is available, we're to use final diagnosis, microscopic, or gross examination in that order. So here we have an example of a chest x-ray which shows a 3.5 centimeter mass. The path report from the surgery states that the same mass is malignant and measures 2.8 centimeters. So in this case, we're going to record the tumor size summary as 0 to 8. And then a second example of a path report which states lung carcinoma 2.1 centimeters by 3.2 by 1.4 centimeters. So in this case, we're going to record the tumor size summary as 032. So if neoadjuvant therapy is followed by surgery, we do not record the size from the pathologic specimen. Code the largest size of tumor prior to neoadjuvant treatment. If it's unknown code, we're going to use 999. So an example of a patient with a 2.2 centimeter mass in the oropharynx. She has a fine needle aspiration of the mass, which confirms squamous cell carcinoma. The patient then receives a course of neoadjuvant chemotherapy. So pathologic size after the total resection is 2.8 centimeters. So in this case, we're going to record the tumor size as 022. If no surgical resection is done, then the largest measurement of the tumor from physical exam, imaging, or other diagnostic procedures prior to any other form of treatment. So this is not saying that the physical exam takes priority over imaging. We're going to cover this a little more in the coding rules. So if 1, 2, and 3 do not apply, the largest size from all information available within 4 months of the date of diagnosis in the absence of disease progression. So tumor size is the diameter of the tumor, not the depth or thickness of the tumor. So recording less than or greater than tumor size. So in that case, if the tumor size is reported as less than X millimeters or less than X centimeters, the reported tumor size should be 1 millimeter less. So here are provided some examples. As you can see, size is less than 10 millimeters, then we're going to code the tumor size as 009. Another example would be if the size is less than 2 centimeters, we're going to code the tumor size as 019. And then here on the bottom, you can see if stated as less than 1 millimeter, we're to code the tumor size as 001. So if the tumor size is reported as more than X millimeters or more than X centimeters, we're to code the size as 1 millimeter more. And some examples of that are here. Size is greater than 10 millimeters, we're to code the tumor size as 011. Or if the size is greater than 2 centimeters, we're to code the tumor size as 021. And then finally, if it's described as anything greater than 989 millimeters, we're to code as 989. So if tumor size is reported as between two sizes, we're to record the tumor size as the midpoint between the two. For example, we'll add the two sizes together and then divide by 2. So an example would be a tumor is described as between 2 and 3 centimeters, then we're going to code the tumor size as 0 to 5. Or if a tumor is described as 3 to 4 centimeters, we're going to code the tumor size as 0.35. So for our rounding rules, round the tumor size only if it is described in fractions of millimeters. If the largest dimension of a tumor is less than 1 millimeter, for example, between 0.1 and 0.9 millimeters, we're going to record the size as 0.01. We're not to round down to 0.00. So an example of this would be a tumor described as 0.3 millimeters, recording tumor size as 0.01. Or a tumor described as 0.8 millimeters, we're going to record the tumor size as 0.01. So if the tumor size is greater than 1 millimeter, round the tenths of millimeters in the 1 to 4 range down to the nearest whole millimeter, or round the tenths of millimeters in the 5 to 9 range up to the nearest whole millimeter. Do not round tumor size expressed in centimeters to the nearest whole centimeters. Rather, move the decimal point 1 space to the right, converting the measurement to millimeters. And then there are some examples provided here of a breast cancer patient described as 6.5 millimeters in size. We're to round up to tumor size as 0.07, or a cancer in a polyp, which is described as 2.3 millimeters in size. We're to round down tumor size as 0.02. Then also another example would be a focus of cancer described as 1.4 millimeters in size. We can round down to 0.01. And finally, 5.2 millimeter breast cancer, round down tumor size to 5 millimeters and code as 0.05. So there are special rounding rules for breast cancer, which can be found in STOR 2018. We're directed to follow the AJCC 8th edition breast chapter. The general rules for rounding to the nearest millimeter do not apply for tumors between 1.0 and 1.5 millimeters, so as not to classify these cancers as microinvasive. And then here an example, a tumor between 1 millimeter and less than 2 millimeters should be reported rounding to 2 millimeters. So here we have a left breast lumpectomy which showed a 1.4 millimeter infiltrating ductal carcinoma. The tumor size summary is rounded up to 2 millimeters and should be coded as 0.02. And then the NCDB updates tumor size summary for coding rule number 4. As noted here, priority of imaging radiographic techniques. Information on size from imaging radiographic techniques can be used to code the tumor size when there is no more specific size information from path or operative report. It should be taken as a lower priority, but over a physical exam. So the coding rule clearly states that the imaging takes priority over physical exam. Physical exam is actually the lowest priority for assigning tumor size. And here we've provided the link to the STOR addendum for this. So to clarify the order of priority, 1 being the priority in recording tumor size. So 1, first is pathology or op report, secondly, the imaging or radiographic technique, and thirdly, the physical exam. And here we also have provided a couple examples. So first, breast cancer patient had a 2.5 centimeter mass on physical exam. The mammogram showed a 1 centimeter mass, and the patient did not have surgery. So in this case, we're going to record the tumor size summary as 0.10. In our second example, we have a physical exam which shows a large, raised, oval-shaped, well-circumcised mass in the left chest, approximately 9 by 7 centimeters in size. The biopsy was positive for sarcoma. The CT of the chest showed a 5.6 times 3.3 centimeter mass in the region of upper pectoralis major muscle. And then the PET scan showed a 6.7 by 8.2 centimeter enhancing hypermetabolic left chest mass. So the patient received neoadjuvant treatment, and then the path resection after the neoadjuvant treatment showed an 8.5 centimeter tumor. So in this case, we're going to record the tumor size as 0.82 from the PET scan. We cannot use the size from the path report because there's no neoadjuvant therapy. The size on the scans, in this case, hold priority over the physical exam. There is no priority order of scans, so we use the largest size as noted. So when a patient has surgery and no size is reported on the path report, record the most accurate measurement of a solid primary tumor based on the rules in STORE. So here we have an example of a CT of the upper abdomen pelvis, which showed a 4.5 centimeter lesion in the left kidney. No abdominal or pelvic lymph nodes, but the op report showed a 4 centimeter mass confined to the left kidney, with no other masses or lesions noted. So the path showed renal cell carcinoma with no size noted. So in this case, use the tumor size from the information noted in the op report when that information is missing on the path report. So in this case, we're going to record tumor size summary as 040. So note, a scope is not treatment or surgery. A colonoscopy, cystectomy report, etc. is not an op report. An op report documents the details of the surgical procedure. So if the tumor size from path, imaging, or op report is not available, then we're to use the tumor size from the physical exam. So an example of this would be a colonoscopy, which states mass at 5 centimeters from anal verge, 5 centimeters in length. So in this case, we're going to record the tumor size summary as 050. So tumor size discrepancies among imaging and radiographic reports. If there is a difference in reported tumor size among imaging and radiographic techniques, unless the physician specifies which imaging is most accurate, record the largest size in the record, regardless of which imaging technique reports it. So an example would be an esophageal patient which has a scope stating tumor extends from 30 to 35 centimeters. The PET CT scan showed a 6 centimeters tumor. So use the size from the PET CT scan and code tumor size summary as 060. As noted here on number 6, always code the size of the primary tumor, not the size of the polyp, ulcer, cyst, or distant mets. However, if the tumor is described as a cystic mass and only the size of the entire mass is given, code the size of the entire mass since the cysts are part of the tumor itself. So record the size of the invasive component if given. However, if both an in situ and invasive component are present and the invasive component is measured, record the size of the invasive component even if it's smaller. So an example of this case would be a tumor mixed in situ and invasive adenocarcinoma, a total of 4.5 centimeters in size, of which 1.5 centimeter is invasive. So in this case, we're going to record the tumor size summary as 015. If the size of the invasive component is not given, record the size of the entire tumor from the surgical report, path report, radiology report, or the clinical exam. So in our first example, we have a breast tumor with infiltrating ductal carcinoma with extensive in situ component. The total size was 2.6 centimeters. In this case, we're going to record the tumor size summary as 026. In our second example, we have a ductal carcinoma in situ measuring 1.8 centimeters with an area of invasive ductal carcinoma. We're going to record the tumor size summary as 018. So record the largest dimension or diameter of tumor, whether it's from an excisional biopsy specimen or the complete resection of the primary tumor. An example of this would be a tumor described as 2.6 by 5.3 by 1.5 centimeters in size. So in this case, we're going to record the tumor size summary as 053. Also note to record the size as stated for purely in situ lesions. Disregard microscopic residual or positive surgical margins when coding tumor size. Microscopic residual tumor does not affect overall tumor size. The status of primary tumor margins may be recorded in separate data items. Do not add the pieces or chips together to create a whole. They may not be from the same location, or they may represent only a very small portion of a larger tumor. However, if the pathologist states an aggregate or composite size, determined by fitting the tumor pieces together and measuring the total size, then we can record that size. So if the only measurement describes pieces or chips, we're to record the tumor size as 999. So for multifocal multicentric tumors, if the tumor is multifocal or if the multiple tumors are reported as a single primary, we're to code the size of the largest invasive tumor. If all of the tumors are in situ, we're to code the largest size of the in situ tumor. We're to code tumor size 999 when size is unknown or not applicable. Sites morphologies where tumor size is not applicable are listed here, which you can see, such as the hematopoietic, Kaposi sarcoma, melanoma, etc. Also document the information to support the coded tumor size in the appropriate text data item of the abstract. And here we have the codes listed to record tumor size summary. As noted, we have 000 for no mass tumor found, 001 for 1 millimeter or described as less than 1 millimeter. For 002 to 988, we're to record the exact size in millimeters. Use 989 for 989 millimeters or larger. Use 990 for microscopic focus or foci only, and no size of focus is given. Use 998 site-specific codes for alternate descriptions of tumor size. As you can see, we have some examples here provided under the rectosigmoid and rectum. If no size is documented, for example, circumferential for esophagus. And then 998 is used for diffuse widespread, 3/4 or more of mass, diffuse entire lung, not otherwise specified, or diffuse of the breast. And then 999 is used for unknown, size not stated or not documented in the patient record, or the size of tumor cannot be assessed. So here's a slide documenting the sources that were used in this presentation, including the 2018 STOR Manual and Addendum, the Cancer Answer Forum, the AJCC 8th edition Breast Chapter, page 601. And then finally, here is our contact information if you have any questions regarding this presentation. Also noted on here is our 1-800 line, and I'd like to thank you for viewing our presentation today.